And today I will talk about the treatment. Like the week before Thanksgiving, Dr. Chung have given a wonderful presentation about how the microbiology lab doing diagnostic for the patient with suspected intestinal parasite infection. Today I will take a follow up that presentation and give a different take on how we would approach and manage this patient so that we can expel those uninvited guests from our gut. So the objective for today's presentation, by the end of this presentation, you should be able to recognize the clinical presentation and the prevention method for the common intestinal parasitic infection. You should also be able to identify the supportive as well as the anti-parasitic therapy for the common intestinal parasitic infection. And as I mentioned, since Dr. Chungin have given a very nice presentation on the microbiology lab work, my presentation will not focus on that, but I do put the link on the presentation. As you can see, if you want to review that, just click on the link and it will lead into his presentation. With that, let's go over again the definition. What is a parasite? So by definition, parasites is an organism that lives on or in a host organism and is get its food from or at the expense of its host. So basically, it's more like a one-way relationship type of situation where the host, for example, like human, will get really any benefit from a parasite, but the parasite will get the food and the energy from us or at the expense of us. Parasites were further categorized into three small groups. One of them is called protozoa. The other one is helminth, and the last one is ectoparasite. So under protozoa, they also further classify into four smaller groups. The first one is amoeba, or an example of that is entamoeba. And then flagellate, and an example of that is giardia. Next one is ciliated. An example of that is Balantidium. And the last one is Sporozoa. And an example of that is Cryptosporidium. Under the helminth section, it will classify into three different groups like flatworm, thorny-headed worm, and roundworm. And obviously the last category of parasite is ectoparasite. For today's purposes, we only focus on the protozoa, especially on the entamoeba, giardia, and cryptosporidium, because they are some of the most common intestinal parasitic infection that you will come across in the United States. So before we go into different parasitic infection, let's meet patient ZT, who is a patient that I have come across at our hospital. And you don't have to respond to the question, but keep that in mind as we go through the presentation. So basically, ZT is a 35 years old male, born and raised in the US, living with HIV, diagnosed about 5 years ago. He reported that he had been non-compliant to HIV medication over a year due to limited access. He presented to the hospital, complaining that he had abdominal pain, non-bloody diarrhea that had been waxing and waning for over a month. He reported that over the last few days, he took some amoxicillin clavulanate that given by his family member, but didn't have any improvement. He denied fever and chills, white blood cell count within normal limit. All other labs were totally stable and unremarkable. How would you approach this patient? Option number A, since the patient had persistent diarrhea, have failed the oral antibiotic, we should have started the patients on an IV treatment with ceftriaxone and metronidazole, because ceftriaxone should be given for everybody who have diarrhea, right? Option B, the patient is immunocompromised and has diarrhea, we better start a broad spectrum antibiotic with anti-pseudomonal coverage with piperacillin tazobactam. Option C, the patient is very immunocompromised, have persistent diarrhea. We should start it with a bigger antibiotic with meropenem. And D, the patient is somewhat is currently stable. We should have do more workup given the patient have persistent diarrhea for over a month, and that included Cryptosporidium and Giardia antigen. So just keep this patient in mind. And then we will come back to these patients as we go through a few infections today. So the first parasitic infections that I want to talk over is cryptosporidiosis, which is an infection caused by a protozoan called Cryptosporidium species. Some remarkable timeline for cryptosporidiosis is that it was first documented in 1955 as a gastrointestinal disease in Turkey, so the turkey that we ate for Thanksgiving. And then in 1971, it's caused bovine diarrhea. But it's not until the 1976 that we have seen the first few human case documented with cryptosporidiosis. In the 1980s, the case of cryptosporidiosis increased associated with the HIV and AIDS epidemic. And in 1993, we have a waterborne outbreak with cryptosporidium in Milwaukee, Wisconsin. So how does cryptosporidiosis get into our bodies and cause problems? So in human or animal, they might have like infected with a cryptosporidium. They pass it to the stool, and the crypto exists in the form of like cysts. Those stool infected with the cysts somehow contaminated the waters or the food, and humans, some people ingested the fecally contaminated water or food, and that is how it gets back to our body and causing problem. When it gets into our body, it can kind of like damage the epithelial of the gastrointestinal self, and that is how it's caused us to have symptoms of GI infection. So how the cryptosporidiosis present? So you shouldn't be surprised with this, right? Since it's go in our body and damage the epithelial cell of our gastrointestinal, the most common complaint you will hear the patient talk about is diarrhea, especially diarrhea for a long time. The major group of patients that get infected are like immunocompetent individuals in high-income country, the childhood diarrhea in low and middle-income country, and usually happen in the children who have malnutrition. People living with HIV, and in the people living with HIV, sometimes cryptosporidium species can cause extra intestinal disease, like involving the biliary and respiratory tract. And then transplant patients, since they also receive immunosuppression therapy, they also at a higher risk for cryptosporidiosis. It has been noted that it's more frequent in the patients who are on tacrolimus compared to like cyclosporine. So the good thing about cryptosporidiosis is that if the patient is immunocompetent, some of them are very self-limited with just supported therapy. So supported therapy is crucial in cryptosporidiosis or just any diarrhea disease state in general. Since those patients with diarrhea, they tend to be dehydrated, we have to make sure that we give the patient hydration, preferably with oral, but in some patients, we might need to give parenteral hydrations if it's severe enough. We want to make sure to give the patient lactose-free diet. And the reason being is because the cryptosporidium species, as mentioned, can go in and damage the epithelial cell in our gastrointestinal tract and cause us to have a reduced lactase enzyme for a period of time. So we can develop a lactose intolerance for a period of time. So we don't want to give a patient who already have diarrhea a lactose diet and make them have more diarrhea. We can also give them some anti-mobility agents to help with the symptom management. For the patients with HIV, we have to make sure that we optimize the antiretroviral therapy because the immune system is what helps them to control the symptoms and infection. Similarly, in the patient with solid organ transplant or stem cell transplant, we want to minimize the immunosuppression regimen that we give to the patient during the infection period. The role of anti-parasitic drug in cryptosporidiosis is somewhat not strongly supported. In some patients, we do consider to give the patient anti-parasitic. And if that's the case, nitazoxanide is one of the medications that have been FDA approval for immunocompetent adult with cryptosporidiosis. If we do give to those patients, the regimen recommended is 500 milligrams by mouth BID for 3 days. Nitazoxanide is not FDA approval in the patient with immunocompromised condition. However, there's some studies support the use of nitazoxanide in patients living with HIV. In fact, the HIV clinical guideline of opportunistic infection recommend that in patients living with HIV, we can consider giving nitazoxanide 500 milligrams to 1,000 milligrams by mouth BID for 14 days, in addition to optimize antiretroviral therapy. So it's not instead of antiretroviral therapy, it's in addition. And the reason for that is because in a subset of patients with HIV that have been studied in the past, they saw that in a patient with a CD4 count greater than 50, when we give the patient nitazoxanide, more patients achieve clinical resolutions compared to placebo. So roughly about 70 to 90% of patients will achieve clinical resolution with nitazoxanide compared to 20% with placebo. However, in the patient with a CD4 count less than 50, then given the use of nitazoxanide in those patients do not boost up the clinical resolution rate compared to placebo. It's roughly about 20% in each arm. So that is why we want to make sure the patient have improved immune system, because that is what actually help the patient with controlling the infection. In the solid organ transplant recipient, we don't have much data in that. However, the guideline kind of extrapolate the recommendation from the patient with HIV and also suggest that nitazoxanide should be considered at the dose of 500 to 1,000 milligrams by mouth BID for 14 days. If for some reason the patients cannot receive nitazoxanide, another agent called paromomycin, which is aminoglycosides that is given orally, non-absorbable, can be considered. In the HIV guideline, it has recommend that it can be given 500 milligrams by mouth QID for 14 to 21 days, again, in addition to optimize antiretroviral therapy. So the best way when it comes to managing cryptosporidiosis is to prevent them, right? We don't want a lot of patients got infected with those infections. So how do we prevent it? Since the most common transmission route is ingesting fecally contaminated food or waters or things like that, some of the common prevention method is that we have to make sure that we have a good hand hygiene so that we don't accidentally contaminate things with our hand. It's also recommended to avoid drinking untreated waters like from the lake, river, or some swimming pool. Avoid food that might be contaminated. In the patients living with HIV, when they have low CD4 count, the CDC have recommended that they should be very cautious when eating raw oyster. And that is because Cryptosporidium can live in raw oyster for up to 2 months. And if they all have low CD4 count, that mean the immune system is not very good. That can cause them get really sick with low cryptos if they got infected. It's also recommended to practice safer sex, for example, like once before and after sexual activity, and using barrier method during sex. And that is because we don't want to get like infected with a fecal material during the direct, like for example, oral to anal sexual activity, or indirect, like penile to oral sexual activity. In the patients with weakened immune system, the CDC also recommend to avoid touching the farm animal and store pet. In the patients who have diagnosed with cryptosporidiosis, I think this is a good thing. One of the things to counsel the patient is that they should have waited 2 weeks after the diarrhea stopped before they go swimming. And that is because cryptosporidium can shed in the stool. So we have, and then the chloride in the swimming pool does not necessarily kill the cryptosporidium. So we have to make sure that diarrhea stop, and that is when the clock start to count to 2 weeks before they go swimming, so that we don't actually cause a waterborne outbreak with like cryptosporidium. And that is all I have for the cryptosporidiosis. Moving on to the next parasitic infection. I don't know if anybody recognize this one yet, but this is like Giardia. So Giardia is an infection caused by a protozoan called Giardia lumpia. It is beside the cryptosporidiosis. Giardia is one of the most common enteric parasites. In the United States, roughly about 17,000 documented infections every year. The common group that getting affected is like children aged between 1 to 9 years old and adult ages 40 to 50 years old. So how does Giardia get into our body and cause infection? So similarly to crypto, Giardia can exist as a yeast, which is an infective state in the stool, and if that infected stool somehow contaminated the water, the food, and things like that, and a human ingests the frequently contaminated food, and that is how we get the infection. So how does patient with Giardia present? Sometimes they will present with acute onset of diarrhea, abdominal pain, bloating, flatulence. They do have an incubation period, roughly about 1 to 2 weeks, which means that they might have a person might ingested Giardia infected food or waters 1 to 2 weeks before they actually presented with diarrhea. And then they can also cause malaise, nausea, and anorexia. They also can complain with sulfuric burning. They do have a flu-like symptoms. So what this means is that the patients might have waxing and waning of symptom of diarrhea, and the diarrhea tend to come out with a small amount of diarrhea, but persists over the period of months. And that is because Giardia can go in and again damage that epithelial of the gastrointestinal, causing the malabsorption. And the patients do also complain of weight loss over time. They also can report that they have a foul-smelling, flatus, and greasy stool. For Giardia treatment, some of the medications that can be used to treat Giardia infection, including like tinidazole 2 grams once time, or nitazoxanide 500 milligram BID for 3 days. If we don't want to use tinidazole, metronidazole can be an alternative, but have to be given over a longer period of time instead of just a one-time dose at 250 milligram BID for 5 to 7 days. And if for some reason the patients cannot receive any of those medication just said, they can also be considered with paramomycin 500 milligram TID for 5 to 10 days. So how do we prevent Giardia? So again, since the most common method of transmission is like injections of fecally contaminated food and water, we have to make sure that similar to how we prevent crypto, we want to make sure that we have a good hand hygiene, avoid the food or water that might be contaminated. We want to make sure to practice a safe sex practice, and that is because Giardia can be persistent in the poop for several weeks. The CDC suggests that we may need to talk about the patients and the doctor to wait to have sex several weeks after diarrhea ceases, just to make sure that we don't give it to other people. And the last method for prevention is obviously we clean and disinfect, make sure that it's not spreading around. So now if the patient get test positive for diarrhea, we treated them and they still have symptoms. Is it a recurrent? Is it reinfected? Is it a treatment failure? How do we approach those patients? So the CDC actually recommend that we need to test the patient for 3 samples, stool sample over several days again to determine if the patient is still infected. If it's negative, we need to think about other things that may cause the patient still have diarrhea. One of them is that similar to crypto, diarrhea can also cause you to have temporary lactate deficiency because of the epithelial cell damage. So the patients might have lactose intolerance, both diarrhea infections, and that can last for several weeks. If it does have been ruled out, they will also need to work up for both diarrhea, irritable bowel syndrome, because in some patients, after the diarrhea infections, they can develop an irritable bowel syndrome as well. We should ask ourselves, did the patients got adequate treatment? Is it like, do the patients got adequate dosing? Does the patient got adequate duration of treatment, or do they just decided to stop the treatment on their own and things like that? If everything else have been checked, if the patient got adequate dosing, got adequate duration of treatment, and still have consistently positive with diarrhea and things like that, and considered to be a treatment failure, then combination therapy can be considered. So that is cryptosporidiosis in diarrhea. Let's go back to our patient ZT. So just a refresher, this is a 35-year-old male born and raised in the US with an HIV, non-compliant to HIV medication, that had non-bloody diarrhea for over a month. All right, how would you approach this patient? And I would hope that everybody would have in their mind is option D, is that since the patient is stable, we should do more workup. And since the patients have diarrhea for a while, for over a month, who is a patient living with HIV, non-compliant with their HIV medications at a high risk, maybe workup for like parasitic infections, and one of the most common one is like cryptosporidium and diarrhea integrum. So in fact, these patients have positive for both cryptosporidium and diarrhea. We did give the patient nitazoxanide, the patient diarrhea resolved within 3 to 4 days on nitazoxanide. So the key takeaway from here is that if your patient is coming with a persistent diarrhea, the answer is not always give the patient more broad-spectrum antibiotic, like your ceftriaxone and metronidazole or your meropenem, do not solve all the problem when it comes to the patient gastrointestinal infection. If we don't do appropriate workup, we cannot really optimize the patient treatment. If we continuously give the patient those spectrum antibiotic for no reason, then the patient might develop another type of diarrhea like C. diff. But that is a complaint for another day. So let's change gear a little bit. After the cryptosporidiosis and the diarrhea, the next one and the last one that I want to talk about is amoebiasis, with some infections caused by Entomoeba, including Entomoeba histolytica. So similarly to crypto and diarrhea, Entomoeba can also spread by fecal oral transmission from person to person, waterborne and foodborne spread. Most infections are in impoverished community in the developing world. However, that does not mean that in a developed world we cannot get amoebiasis. I don't know if anybody recognized the man in the picture, but his is just a fun fact. He's a King Louis XIV. I would imagine that he is one of the richest men at that time. And then he did get amoebiasis and had to go treated for it. So it's not like impossible to get infection even if you live in a developed world. Hemoptysis is a common cause for diarrhea, especially for returning international traveler as well. So how do entamoeba get into our bodies and what is their life cycle? So similar to Cryptoenteria, they can get ingested to our body through a fecally contaminated food or water and things like that. Um, an entamoeba can exist in a cyst form and a trophozoite form. So the cyst form is the infected state, where when we ingested the food is in the cyst form. When it get into our body, the cyst form can transform into the trophozoite form. When it's in the trophozoite form, it can either maintain in the luminal region and just stay there and causing no problem. So those patients tend to be an asymptomatic carrier. However, some patients, the trophozoite, decided to invade the intestinal self and causing the invasive infection. In some patients, if the trophozoite can go out of the intestinal and go into the liver and cause liver abscesses. From the liver abscesses, in some patients, they can go to other organs like the lungs and the brain and causing problems. So how the amoebiasis are presented? So as I mentioned, sometimes if the trophozoite decided to just stay in the luminal area, then the patient doesn't have any symptom. In fact, a lot of patients do not have symptoms, up to about 80% of them. However, if they start to get damage in the gastrointestinal self, then that is when the patients develop like amoebic diarrhea. And then it can lead to dysentery or colitis as well. Dysentery means that the diarrhea have become like have mucus and a visible or microscopic blood. The onset tend to be gradual over 3 to 4 weeks, and the patient also have like abdominal pain. In some patients, they can cause appendicitis up to about 15% of the patient in HIV infected patients do develop appendicitis in addition with colitis. In the patients with appendicitis, they tend to have higher white blood cell count compared to those just have colitis by itself. As I mentioned, sometimes like entamoeba can go out the intestinal and go into the liver and cause a liver abscess. It's actually 10 times more common in men than women in terms of developing liver abscesses. So in the United States, the most common populations that you will see an amoebic liver abscess in about like 40 years old Hispanic men. That doesn't mean that women will never develop liver abscess due to amoeba. It's just like the odds would be higher in men compared to women. One of the things that we need to look for is that the liver abscess can develop 20 years after the last visit to the endemic area. So history is key when it comes to those diagnoses and things like that. In those patients, they tend to have fever, cough, constant dual aching abdominal pain in the right upper quadrant. If you do a physical exam on those patients, they will have a hepatomegaly and have some tenderness over the liver. From the liver abscesses, again, they can go to other organs like the thoracic, pericardial, and cerebral abscesses. So how do we treat amoebiasis? So depend whether or not the patient has symptoms. If the patient is asymptomatic, then it's recommended that we only give them luminal agents like parasite just to make sure that they will not like pass on and infect other people. If they have like liver abscesses or colitis, we have to give them a systemic agents like metronidazole or tinidazole, followed by a luminal agents like parasite. If the patients have a very large, like liver abscess greater than 5 to 10 centimeters, we want to do a percutaneous drainage as well to have some source control. And if the patient have colitis complicated by toxic megacolon, perforation, peritonitis, then surgical treatment might be indicated. In terms of preventions, nothing is sudden. It's very similar to crypto and Sharia. We want to make sure we don't ingest it, minimize the chance that we ingested fecal contaminated food and water, safe practice, and we want to make sure the water we drink is safe. And with that, the intestinal parasite management key takeaway is that the intestinal parasite protozoan can cause persistent chronic diarrhea. So if your patient's coming in with like those type of symptoms, make sure to start thinking, have some clinical suspicion about other things than just bacteria, gastrointestinal infections, because sometimes antibiotic is not the like ceftriaxone or metronidazole is not the answer to every diarrhea. Intestinal parasite management includes supportive therapy, plus anti-parasitic therapy, and obviously intestinal parasite infections can be prevented just from hand washing. We want safe sex practice, and we want to minimize the chance we ingest the fecal contamination of food and water. And that is all I have. I will open up the floor for any questions.
Clover, I would like to thank you for the baby shark hygiene video. I rest assured that will now stay in my brain for at least the next 2 weeks. So thank you for the graphic there. Does anybody have any questions? All right, this was very good information, and thank you for sharing.
Thank you for having me. Have a great day.
Thank you, you too.